January 1st, 2016 marked the start date for several new policies for Medicare, the federal government health insurance program primarily for people 65 and older. A few of those policy changes are related to end-of-life planning and care. This is especially relevant since about 75% of the 2.5 million people in the United States who will die this year are Medicare eligible. One of those changes has to do with conversations between physician and patient.
How are you today?
Pretty good. Things have been going pretty well for me. I'm very satisfied with my life right now. Sometimes I'd like to be able to travel. I don't know if that's ever going to be possible again, but I don't have really much to complain about.
Medicare has previously paid for patients to have an end-of-life planning conversation with their doctor just once. This occurred during their initial Welcome to Medicare conversation, when end-of-life issues are the last thing on a new enrollee's mind. These talks can be very difficult, but should ideally lead to the completion of state-mandated forms called end-of-life directives. These describe the patient's wishes regarding their own death and dictate a wide range of actions, from total and aggressive medical interventions to do not resuscitate or DNR orders. All directives should also designate a medical power of attorney. Beginning this year, Medicare will now pay for patients and doctors to have more of these sensitive and lengthy conversations.
From what we know of physicians and the other practitioners, like nurse practitioners and so forth, that would take advantage of this benefit, they're very busy people, and this is not something that you can jam into a couple minutes in the hallway. You have to take some time and think about it. So I think the fact that it can be reimbursed is a little bit more desirable if you're going to plan to set aside, 30 minutes or 60 minutes with one patient that's going to take a big piece out of your day. It just seems a natural thing.
David Sayin is the Medicare Regional Administrator for District 9. Headquartered in San Francisco, California, District 9 includes California, Nevada, Hawaii, and Arizona.
If we don't know what the patient wants to do at the time that we have to make a decision and she's not able to tell us, how could it be patient-centered care? So I think it's about families and patients and about physicians being more comfortable not having to guess or decide for themselves, how to make decisions about what treatments to give people.
The way reimbursement is now, it's more based on quantity, the number of patients you see, how quickly you see them. But there's been a real shift in medicine more towards value-based care. Does the care you provide actually provide quality care? And is it cost-effective care as well? And I think this is in line with that. I think to reimburse physicians to actually sit down and spend the time with patients, they'll be more likely to have them. And I think most physicians want to have these conversations.
Dr. Gobi Paramanandam is with the Hospice of the Valley in Phoenix.
If that conversation's not had, it's often automatically assumed that a patient would want everything. And as a medical system, that's the way we're designed. If a patient comes in, we'll continue to treat and we'll continue to aggressively treat until someone says to stop that treatment. If it's not in writing, it's very difficult. So if there's a situation where a patient is unable to communicate, then it goes to a surrogate. Or ideally you have a medical power of attorney. But if you don't have paperwork, right, then it falls to your family members. And that's a difficult place to put a family member. There can be a lot of guilt surrounding those decisions, especially if a conversation hasn't been had prior into what your wishes are.
That's what I'm afraid of, the whole hospital, rehab, all that stuff. I don't want to be a major distraction in negative sense to my daughter.
But having these conversations early allows people to be able to make more informed decisions when they get into the hospital, when some of these issues may occur. And for some patients, actually, we've prevented that last hospitalization. And I know we've discussed in the past some of these conditions. Unfortunately, there's not a cure. They're not going to go away. They're treatable, definitely, but not curable. Knowing that, what are your goals? What are your hopes? What are your fears?
Well, I'm not afraid of much at this point.
Have you thought about what you would want if the disease did progress?
I would want to go into hospice.
Hospice is specialized care for patients with a terminal diagnosis. So for a patient to get the benefits of hospice, two physicians need to state that a patient, in their best estimation, has 6 months or less to live. The goal is to focus on improving or maintaining a patient's quality of life and allowing them to live well in the days or months that they have left. With hospice care, a patient does need to give up aggressive care to receive hospice care.
For people who have a terminal illness, there is a Medicare benefit called a hospice benefit that provides things that Medicare wouldn't normally cover. That is a valuable service. We don't think enough people take advantage of it. Many people only do it at the very end of their life because they view it as sort of throwing in the towel, if you will, because the way the law is constructed, when you opt to receive those benefits, you're no longer getting the other Medicare benefits like chemotherapy, like radiation that might be trying to save your life.
Although they use different terms, another Medicare benefit is the practice of palliative care or comfort care.
Does it go up the calf or just up the side?
It goes up right here.
So palliative care is not necessarily geared towards curing the disease. It's more of a supportive care. So similar to hospice, palliative care can address the physical, emotional, and social needs of a terminal diagnosis or a serious illness. The most important distinction with palliative care is that you can continue with aggressive treatments while you get palliative care. So for example, that end-stage cancer patient can continue with chemotherapy and radiation and get concurrent palliative care. End-stage kidney disease patient can continue dialysis and still get palliative care. They're not mutually exclusive. Palliative care is not always hospice care, but hospice care is always palliative care.
Medicare does pay for palliative care during hospice. However, the inability of Medicare to pay for curative or aggressive care in conjunction with hospice care has led to another change beginning in 2016. A multi-year study is now underway at over 140 hospices nationwide, looking at the possibility of providing both kinds of care to beneficiaries.
This program, the Medicare Care Choices model, will allow people who have been diagnosed with a terminal disease to continue curative treatment for their disease and at the same time access some of the palliative care benefits of the Medicare hospice benefit, like social work counseling, like counseling for the family, like some dietary work, perhaps some help in the home, at the same time where normally a person would cease the curative treatment and go into the hospice program. So, I mean, what we believe is, or we'd like to determine is, giving this fuller, richer sets of benefits will result in a better patient-centered experience for the patient, family, caregivers, and we're very excited about it.
Hi, don't you look cute? Hi! Oh, look at Gwen.
The Care Choices model allows for a patient to have both, to continue with their aggressive care, their curative care, but to at the same time have concurrent palliative care. So there are certain criteria. So a patient at this time would have to qualify for hospice. So again, patient that would have potentially, again, in the best estimation of their physician, 6 months or less to live. So if they were hospice appropriate, but still seeking aggressive care, they would qualify for this program. They would also have to have 2 hospitalizations related to their terminal diagnosis to qualify for the program, as well as 3 visits with the physician treating that diagnosis as well. So Hospice Valley was the only hospice in Arizona actually selected for the Care Choices program. We've had a palliative care program in one way or another for almost 15 years.
I don't know if I can hear over this jacket or not, but we'll try it. Oh, speaking of that, how's the blood pressure's been?
Gwen Sargent would qualify for the Medicare Care Choices model to receive curative care while in hospice. She's currently under the care of her older twin sisters.
She has non-Hodgkin's lymphoma, mantle cell, and so they have helped us, the palliative care have helped us evaluate and know that what we're doing is going along all right. She was in a group home, And so once she became ill, we moved her out of there, and then we move her between our two houses as our schedule works for us, depending on what's happening. So usually she spends 2 weeks at one house and 2 at another. And so far, she's been very happy with moving in between the houses.
And I really didn't know specifically the difference between palliative care and hospice care. In fact, that was one of my first questions. The first time they came was, if we choose palliative care, can she still continue to be treated? I wanted to know that because if they wouldn't, we weren't ready for that. That she could continue on medication, that they would treat the situation that was occurring. And it was to be our choice. And we wanted to continue, we wanted to try this new medication.
Knowing that they have an option, they don't have to choose one or another. I think they'll be more open to palliative care. I also think in the long run they'll be more open to hospice care, because I think many people think hospice care is a place where you go and you die, where actually hospice is a philosophy of care for patients, and majority of the patients end up at home. They die in home. So I think more people will be receptive to palliative care, but I think also in turn more people will end up being more receptive to hospice care as well, because they'll have a better understanding of what it actually is.
Some of the Medicare Care Choices study sites will start to receive reimbursement from Medicare in 2016. The others, including Hospice of the Valley, won't get reimbursements until 2018, but they have already begun providing dual care.
We are the largest not-for-profit hospice in Arizona, so we were able to even fund this when Medicare wasn't paying for this, able to fund this with donation dollars. Recently, we've had some relationships with Medicare Advantage plans that are paying for this.
Private insurance companies can offer a Medicare Advantage plan. This kind of plan contracts with Medicare to provide a patient's total Medicare benefits through their company. Even before the 2016 Medicare Care Choices project, Cigna partnered with Hospice of the Valley to study the feasibility of offering these dual benefits.
We at Cigna Medical Group established a pilot project for palliative care about 2 years ago. Again, we identified that there were a lot of patients who seemed to have a need for additional levels of service to address their serious and chronic medical conditions that we couldn't meet necessarily in the clinic or through the hospital. And we really wanted to try to develop a continuum of care for those patients that included a home-based project or a home-based level of care. Being in the palliative care program does not exclude curative treatments or treatments that include hospitalization, for example. It doesn't obligate a patient to disengage from their primary physician or from their specialist. They can access all of those services while at the same time receiving comfort care in their home. It is a standard practice for the medical group now. We actually moved from our pilot program within a couple of months because it was simply so successful. We had such a really overwhelmingly positive response, not only from the patients, but from the clinicians who referred them.
Hello. Oh, look at that hat.
The Medicare Care Choices study will take several years to determine the costs, the benefits, and the feasibility of providing palliative and curative care simultaneously. However, some patients who would be eligible for the program, like Pamela Barnes, are already receiving this type of care and feel it is making a difference.
So when I was diagnosed with cancer about the time that my husband died, they were the first people that I called, because I knew it was a matter of time that I was going to need to have somebody there for me on a regular basis. I had pancreatic cancer, so if I didn't take chemo, I would probably only live about 6 months. So right now, with 2 little great-grandchildren, I would like to live longer than that, but God only knows. I hate to rely on people. So at some point, I will have to. So
Yeah, as much as you can do it yourself. We look at the whole person, not just the cancer or the heart disease or whatever it is. And I think, we look at their mental state, we look at their emotional state. We try to solve problems that other people don't even consider. I think it's the wave of the future, and we're all about prevention, so it's going to save, obviously in the long run, the taxpayers, if we can keep people out of the hospital, keep them out of the emergency rooms. So I can only hope that Medicare will see the benefit in it. It's definitely a big service to people when they need it.
The Medicare Care Choices model, I think, is really important. It shows that Medicare cares about this type of care. And I'm hoping for good things from here.